Craig McLean, and I'm Chief of GI at the Robley Rex VA and Associate Vice President for Health Affairs Research at the University of Louisville. This is our second virtual grand rounds of the year. We appreciate Jason Puckett's help. We have two old gastroenterologists that are technically challenged here, and so far everything seems to be going okay. So we're thrilled to have Bruce Yacyshyn giving grand rounds today, talking about GI bleeding. So we were fortunate enough to recruit Bruce to the faculty here less than a year ago. He actually just started in January of this year. Bruce is a native of Edmonton, Canada. He did his medical training in Canada. He then did his GI fellowship at WashU, actually at the same time that Dr. Marsano was there. He's worked in industry. He's been in academics. Most recently, he was at the University of Cincinnati before we recruited him here. He's internationally known for his work in both C. diff colitis and inflammatory bowel disease. He also works on angioectasia, and that relates to the GI bleeding talk that he'll give today. Now, our previous chairman of medicine, Jesse Roman, always gave a little history. I think instead of talking about traditional history, each grand rounds for a while should talk about COVID history or COVID impact. And indeed, that's what our last grand rounds was on. So I'll talk about how COVID impacted Bruce. So one of his beautiful daughters just got married, but that impacts the wedding. So he had to have it in a farm-like setting. And so less people were coming, more social distancing. And it turned out then that none of his family could come from Canada. So this is either the cup half full or half empty, that less people came. It was still a great wedding, and Bruce probably paid a lot of less money to do the whole thing. So without further ado, Bruce, let's hear about GI bleeding.
Yeah, thank you for the kind introduction, Dr. McLean. I much appreciate it. I wanted to fill you in on GI bleeding, and as Dr. McLean mentioned, how it ties into intestinal inflammation and some new concepts that I'd be happy to discuss from a paper that is in press currently in Clinical and Translational Research in Medicine. When you see this picture here, this is something that, this is a picture I wanted to share with you, because that red line here across, the red strand is, when you first see it, when you're a young endoscopist, you assume that's a clot across the lumen of some structure, and what it is not a strand of clot. That's actually a high pressure jet that with active bleeding squirting across the lumen at a force that means it's uninterrupted, which is something that we learned very quickly, that when we see the equivalent drop in blood pressure and increase in pulse rate occurring at the same time as this is being observed endoscopically. So there's more to GI bleeding than meets the eye on the scope, and that's the topic of the talk today. I'm happy to bring up these objectives to discuss implications of upper and lower GI bleeding, to know the timing and role of endoscopic therapy, to understand the importance of early medical stabilization, to be aware of the advances in medical therapy, and how to understand how to reduce rebleeding. I'm fortunate that I've got a brother that's one of my family members that couldn't make it to the wedding, was a brother that is currently doing a short period of time with as a rotational practice as a radiologist up in Yellowknife, Northwest Territories. So he was kind to send 3 slides. This is not a painting. This is a photograph of the lake in the center of the city of Yellowknife in the Northwest Territories. And you can see from the color of the leaves, the fall has progressed, and this lake is in the center of town, if you can believe it or not. And this is a real picture from 2 days ago, showing you the state of fall in that part of the world, which is just under 3,000 miles away from us. So the GI, getting back to GI bleeding burden, if you look at it, the total incidence is massive. It's a large number of patients. We see this on a regular daily basis. Admitted to hospital with GI bleeding. You can see the numbers of cases there, and this is 2019 statistics. Upper GI bleed, 181,600. Lower GI bleed, 144,400. So the rates of GI bleeding totally are 265 per 100,000, slightly more lower than upper GI bleeding, partly due to the fact that we do have a somewhat aging population, and we have decreased some of the upper GI risks with understanding the pathophysiology of upper GI bleeding. So the first patient I'm going to talk about is a case of upper GI bleeding. I have a later case that's lower GI bleeding. This is a real patient, 46-year-old male, married, 3 children, works as a car sales manager for a local dealership, presented at the emergency room at a regional hospital with several weeks of diarrhea, a vague upper GI abdominal pain and headache with dizziness. And if we were in real time and talking personally, I would select a house officer to give a differential diagnosis. But since we are making do with our current environment and situation, I will tell you further that the blood pressure in the ER was 85/60 in both arms lying down, so he's somewhat hypotensive. Physical exam was unremarkable. He had no significant comorbidities, and the family history of diabetes and hypertension was in both of his parents. Both are alive in their 70s. He has 2 siblings who are both well. Electrolytes were interesting. Sodium 128, potassium 5.8, abnormal, which triggered the house officer's thoughts that perhaps a short ghost-entropin test should be done, which was abnormal in keeping with the electrolyte abnormalities that were observed, and also a fasting AM cortisol was 2 micrograms per deciliter, which is low. Fasting glucose was 40 milligrams per deciliter, which is also low. The patient was diagnosed with primary Addison's disease, started on IV hydrocortisone, 100 milligrams TID, while in hospital. While in hospital, after 3 days of medical stabilization, patient passed 200 cc's of melon in the morning as witnessed by his nurse. Patient was started then on normal saline at 250 cc's per hour, and the primary service was notified and GI was consulted. IV pantoprazole, a proton pump inhibitor, was started at 80 milligram bolus, followed by an 8 milligram per hour infusion. That afternoon, EGD was performed by the GI service, revealing a 1 centimeter bleeding duodenal ulcer, which was injected with epinephrine and clipped. So this patient is one presented with a stable situation, which due to medications and confounding medical status ended up with an acute GI bleed while in hospital. Mortality rate of upper GI bleeding, if you look at this graph, which is from the latest data on this is from this is a summary from 2015, but the data is from 2009, showing that it has dropped somewhere. If you look at variceal bleeding, still higher, obviously, than non-variceal bleeding due to the comorbidities associated with varices, and 2.1%. So it's not trivial, it is significant. One of the issues that we deal with is that the technology has improved. Our ideas of medical stabilization have improved, but we're not there altogether yet, as you can tell by those mortality rates. So the etiology of upper GI bleeding includes peptic ulcer, which we just observed in this patient, esophageal varices, which we mentioned, esophagitis and gastritis, anterior venous malformations, or angioectasia, and GAVE, which I suspect are due to similar pathophysiologies, and I'll explain why. Mallory-Weiss syndrome, or repetitive emesis, followed by GI bleeding due to a tearing, malignancy, Dieulafoy lesion, and at the bottom, rare aortoenteric fistulas, hemophilia, and hemosuccus pancreatitis, which is bleeding due to typically a pancreatic lesion such as a pseudocyst or lesion of the pancreas that bleeds through the pancreatic duct into the intestine. Peptic ulcer etiologies, being that it's number 1 on our list, includes Helicobacter pylori. It's nice to talk to about an infectious organism other than what we typically are right now. Aspirin and NSAIDs, antithrombotic medications, have made life challenging, in particular through use of anticoagulation, including P2Y12 inhibitors, anticoagulants, and dual and triple antithrombotic therapies. Malignancies, including carcinoma, lymphoma, and myosarcoma, And then, of course, not to forget the exam favorites, acid hypersecretion, including Zollinger-Ellison syndrome, rare and idiopathic causes. So here's a picture of Helicobacter pylori in gastritis. These are microaerophilic, gram-negative curved rods that you can kind of see from this picture that permeate into the epithelium of the stomach and cause the pathophysiology that we see, and it's typically urease neutralizing at local pH. It attacks directly to the gastric epithelium and induces inflammation for nutrition, which is IL-8 mediated. And it evades the host response through non-invasive characteristics. And it was interesting to read that in studies of Hepatology that Helicobacter pylori has been identified in preserved gastric tissue in Egyptian mummies dating back 3,000 years. So it's a host. It is a visitor that has perplexed us as hosts for many centuries. The diagnosis is tests for active HP infections, fecal HP antigen tests, which I was involved with the validation through Meridian Labs. This test is fecal testing, which I do quite frequently as well. This is C13 or C14 breath tests, not done as frequently, but very useful. Serology, IgG, which is least helpful because they indicate a lifelong immunity to the organism and not necessarily active infection. Invasive testing includes rapid urease, such as the flow test, histology, and culture. Another condition associated with GI bleeding, and I put this up because it is relevant, but it also has some nice pictures, is characterized by massive foveolar hypoplasia with cystic dilation and protein-losing gastropathy and edema associated with hypoalbuminemia. Here's a nice picture of these giant gastric folds looking from an endoscopic view of the stomach. They look like a ball of snakes or worms in the stomach, and they're pretty hard to miss. Gastropathies are characterized by injury to surface epithelial cells without associated inflammation. Common causes of these include NSAIDs, ethanol, and stress-related mucosal disease. The things that punch out or cause leakiness in the stomach, and you can expect that these agents do that through various mechanisms, inciting and triggering inflammation of the stomach. NSAID gastropathy is something that we like to talk about because it is so common. NSAIDs are associated with 0.52% risk of ulcer bleeding. It's dose dependent. There's variable risks. Typically, we see it in the first month of treatment. This is a common question I like to ask on the wards is when do you see bleeding, the first month or the third month? And typically, if you make it through to the fourth month, you've not established yourself as a bleeder from NSAIDs, but if you take the medication for a month and bleed, that's the more typical presentation. Risk factors include age over 75, history of prior peptic ulcer disease, GI bleeding, or heart disease, concurrent use of steroids. We also see this as well in people with chronic obstructive pulmonary disease more as well. Mechanisms are a local or topical effect, weak acid effect on stomach mucosa. It's also seen with bisphosphonates. These are osteoporosis drugs, which act very similarly to the NSAIDs when it comes to causing symptoms, the symptom and signs of GI bleeding. There's also a systemic antiprostanoid or prostaglandin effect, which is a major effect with loss of cytoprotection. It does not depend on route of administration. That is, suppositories equal tablets equal stream creams. So when you see the new NSAID creams, remember in a high enough dose, those are recirculated. And again, suppositories of NSAIDs, just because you don't the recirculation associated with the excellent absorption of a rectal suppository and recirculation back to the gastric mucosa is enough to trigger the disease. So route of administration, not necessarily important. Type of medication, very important. I always like to put this picture of the Bayer aspirin box up. Back when I was a fellow, we used to be able to tell if a patient had a GI bleed due to aspirin because the patient would have a Bayer spot in the stomach. If I was listening to you live, I might expect either groans or chuckling. So at this point, I'll move on to the next slide. So initial upper GI bleeding management, assess the hemodynamic status immediately, insert 2 large bore IVs and begin resuscitation. Blood transfusions, target hemoglobin of greater than 7, greater than 9 if intravascular volume depleted or with coronary artery disease. It's important to risk stratify patients high risk versus low risk, and there are several papers that we'll discuss with respect to that, how to pick your risks of patients. This is a summary chart of transfusion resuscitation restrictive versus liberal. We now do not give as much blood as we used to, and you can tell by this hazard ratio towards restrictive strategy being better. If you look here to the left here, that we try and maintain a hemoglobin of over 7. We don't go to the greater than 9 hemoglobin, which we used to do, because obviously there's not an advantage, and these are seen in patients with cirrhosis, bleeding from varices, and bleeding from peptic ulcers. The risk stratification for upper GI bleeding, there's two consensus here. International consensus guidelines, early risk stratification by using validated prognostic scales. Secondly, ACG practice guidelines, the American College of Gastroenterology practice guidelines. Risk assessment should be performed to stratify patients into higher or low risk categories. It's important to know this because you need to know when to scope, you need to know how to manage medically, and you need to know what to tell the patient and their families with respect to options they're given at the time of presentation of GI bleeding. So there are several scores that we talk about. I'm going to talk about the two key ones. Glasgow-Blatchford score assesses need for intervention by endoscopy when a patient presents with GI bleeding. It has 8 categories with weighted scores. It's best validated to predict low risk. So if a patient is unlikely to have problems, it can pick those out the best. High risk for rebleeding with score greater than 10 and mortality with score greater than 12. Then there's the AIMS 65 score, which is published by Saltzman from Harvard, which assesses mortality. It has 5 discrete categories. We're going to go into that in the next slide. Best to predict mortality and higher risk outcomes with a score greater than 2. So the Glasgow-Blatchford scale, if you can see these, typically systolic blood pressure, other markers including heart rate, melena, syncope, cardiac risk factors, and liver risk factors are all weighted. The European Society for Gastrointestinal Endoscopy guidelines recommends this the Glasgow-Blatchford scale for pre-endoscopic risk stratification. Outpatients are determined to be at very low risk if they have a GBS score of 0 to 1 and do not require area endoscopy nor hospital admission. The discharged patient should be informed of the risk of recurrent bleeding and advised to maintain contact with the discharging hospital, however, if they're sent home with a score of 0 to 1. These are typically young patients. Some of them may have no hemodynamic implications, very few or no comorbidities, and these are ones that are monitored and discharged home for outpatient endoscopy. Typically, however, AIMS 65, we look at the albumin, and you can see the acronym comes from albumin, INR, mental changes, systolic, and age over 65. These look at albumin less than 3, which in a number of internal medicine conditions, the low albumin is sort of the key factor as well. I know it by the Detsky score, one of my mentors from internal medicine from the University of Toronto. The low albumin predicts perioperative mortality, and INR less than greater than 1.5. Important for that same reason that the patient is less likely to maintain self-hemostasis. Mental changes, which implicate lack of reservoir or plasticity in that particular individual or patient, with other systemic issues. Systolic blood pressure less than 90, and age over 65, of course, associated with the other comorbidities of that brought on with ages over that 65 cutoff. So the ACG, American College of Gastroenterology guidelines for proton pump recommendations, and we talk about proton pumps because obviously when a patient has a GI bleed, we want to know what to do first. And what we have done is at the beginning we put in 2 large bore intravenous catheters, and we begin intravenous proton pump therapy with an 80 milligram bolus followed by 8 milligrams per hour for a continuous infusion. This is a patient with active bleeding, non-bleeding visible vessel, or an adherent clot. However, there's some discussion about that. See here, in the past, whereas we used to use continuous infusion, There's now some favored roles for using bolus infusions of proton pump inhibitors. You can hear that boluses work at least, if not equal to, or somewhat better than constant infusions. So if you're in a unit and on a surgical floor or medical floor and you're giving your patient with a GI bleed bolus PPI intravenously, that is absolutely satisfactory. In the past, it may not have been thought so because of intuitive issues relating to whether an intravenous medication can be advantageous. However, we can see the evidence-based medicine does favor bolus infusions of a PPI in that circumstance, in that clinical context. So the ESG guideline on endoscopic timing then becomes the pertinent. So we've got the patient with the IV in place. We've started them on their PPIs. Now we're following hemodynamic resuscitation. ESGE recommends early, less than or equal to 24 hours upper GI endoscopy. Very early, less than 12 hours, which we call emergent endoscopy, may be considered in high-risk clinical categories. That would include hemodynamic instability in some contexts in bloody hospital emesis, nasogastric aspirate, such as our patient that we presented today. Contraindication to the interruption of anticoagulation. We most typically on a cardiac floor when the patient is received cardiac intervention, including angiography and or stent insertion, and the consideration for interruption of anticoagulation would not be made. The worst outcomes may occur with emergent endoscopy, however. So if you're rushing to scope someone with a GI bleed, this is another counterintuitive thought that you would think that you do better. However, as we've seen in a number of technologies, when the technology is good but not there as a 100% efficacious therapy, and we've seen this in cardiac technologies, including angiography, which I've mentioned back in the 90s, patients that were not medically stabilized before angiography did worse. But now, with the advances in that technology, we know the sooner the patient gets angiography, the better they did. We're in the same evolution with emergent endoscopy, at least I hope we are, where without inadequate resuscitation, the procedure without usual supports, or a procedure done at off hours, the endoscopist may be fatigued, a decrease in endoscopic performance quality, and lack of backup for surgical options, including interventional radiology and surgery. We've become much more dependent on interventional radiology for difficult patients. That technology has really advanced in the last decade. Endoscopically, we've made progress, but we're waiting for improvements, and that is one reason why you'll see this next slide explain there's higher mortality patients with ASAs, and these are perioperative mortality predictors. You can see the ASA 1 and 2 and ASA 3 and 5. These are pre-op surgical assessment criteria with numbers of cases, with numbers of predictors. Patients with ASA 1 or 2 would be considered those with no or mild comorbidities. Patients with ASA 3 or 5 have moderate to severe comorbidities. You can see that the mortality in those patients with the low comorbidity rate, if you do the procedure here between 0 and 30, even 40 hours, there's very little effect in terms of delaying that procedure and when they're hemodynamically stable. However, if you have an unstable patient with a lot of comorbidities, you can see that in the first 20 hours, there's actually a negative impact on mortality, scoping someone rapidly with comorbidities, and the same situation occurs here after this roughly 35-hour period. Here we have a hemodynamically unstable patient, the same U-shaped curves. These are not linear curves, these are U-shaped curves exist with ASA 1 and 2 and 3 and 5. So very important is the first 20 hours when patients are monitored and resuscitated before we head in with a scope to try and maintain or establish hemostasis. This is and as I explained, this is technologically driven. We've seen changes like this occur in cardiology. We've seen this occur in other issues, other surgical issues, but with endoscopy, we're getting there, but we're waiting for some things that produce great hemostasis. Some of the things that are being checked or tested include hemosprays that are being given. Those are not ready for prime time. Those aren't available yet. They've been tested in various countries including Canada and the UK, but they're not yet readily available to produce these dissolvable bandages over bleeding lesions that haven't been shown to produce a benefit. Summary of timing. Immersion endoscopy, again, more endoscopic therapy is performed, no improvement in overall patient outcomes. Benefits only patients with active bleeding, and it may be associated with worse outcomes. Urgent or early endoscopy within 24 hours, decreased length of stay and costs. Similar patient outcomes to immersion endoscopy, but with reduced length of stay and costs. So, not to go without mentioning the impact of COVID-19 on upper GI bleeding, there are less admissions for upper GI bleeding now. We're seeing a 40% drop over the country, and these are two papers hot off the press from May. Sicker patients, less hemoglobin, more transfusions, less upper endoscopies are being done, likely to minimize aerosol regenerating procedures. We all scope now with, after completing YouTube-based training in many cases, and the process to deal with known COVID positive patients is quite time consuming and challenging. However, we're doing this in many locations, and so far we've been becoming more confident and capable, but these again are challenging times. We are doing more capsule endoscopies and angiographies. The outcomes are similar with respect to mortality. We haven't seen an increase in mortality in the current environment. Here's another picture I thought I'd show you of the current environment. This is again a picture from my brother of Yellowknife, and if you see that structure up to the top right here, that is the Yellowknife Hospital. It's hard to believe that this is actually a substantial city with this kind of green space in the center, but you can imagine the patient with that view looking out across that lake at this time of year has got, in fact, a resort view on their hands. The lower GI bleeding patients, what I'm proposing to talk about here is a patient that is a patient AB, 83-year-old female with multiple medical problems, including congestive heart failure, mild to moderate mitral regurg with an ejection fraction of 45%. Not bad. History of dextrocardia, however, with atrial fibrillation with a TIA history. The patient's paced. Many of our patients, especially with lower GI bleeding, as I mentioned earlier, have comorbidities, somewhat older age group than upper GI. Recently, the patient had metal coronary stents 2 months ago and started on Pradaxa. Coumadin was stopped at that time due to a history of chronic lower GI bleed. At that time was normal. The colonoscopy was planned but not done. So out of hospital, the patient unfortunately experienced bradycardia-related arrest with troponins that were positive, negative chest X-ray and CT scan of the chest. The patient was extubated at family request. They frankly did not think she was going to make it. However, 4 days later, she awoke, discussed the current news of the day, and was hemodynamically stable with lower GI bleeding, with maroon stool, and no hemodynamic effects noted by nursing staff. So an EGD was performed, revealing a hiatus hernia and mild gastritis, no old or fresh blood seen. And the reason is that 15% in some series of upper GI bleeds produce clinically suspicious lower GI bleeding symptoms. For one reason we clear, and you'll see in the algorithm later, we will do an EGD, rule out that as a source of lower GI presentation. Colonoscopy was performed fortunately at the same time, which revealed sigmoid colon diverticulosis with one bleeding angioectasia in the sigmoid colon, which was treated with a hemostatic clip, epinephrine injection, and tattooed. So this is a photograph of an intestinal angioectasia. This is a picture that was taken by one of my colleagues at Cincinnati, Milton Smith, and I appreciate this picture. It's a picture of this vascular lesion that extends in the epithelium and subepithelial layers. It's no more than 10 millimeters in depth. They're superficial, but they do bleed, and they're a very common cause of lower GI bleeds now. Fortunately, we decided several years ago to start to determine what they're due to and whether or not, in fact, they have a connection with inflammation and potentially other aspects of GI bacterial flora, which I will show you some slides at the end of the talk on how we looked at this, how we evaluated their impact, how we got some clues of their pathophysiology, and how we turned that into a potential path forward for therapy. Talking about lakes, that was a vascular lake. This is another photograph of that lake in the middle of Yellowknife. You can see here the shore grains and the plants in the background with the Permian rock formation in the proximity. This is an old ancient rock formation that has been eroded over time and produces the appearance that you see there, with the forest in the background being a transitional forest before it hits permafrost and tundra. So this is an interesting slide, and I don't like putting up complicated slides, but however, this slide, if you look at it up to halfway, it kind of gives the point that, again, with lower GI bleeding, when you look at risk assessments and management, you have two patient populations, high and low risk. The high and low risk patients are really the same high and low risk patients you see with upper GI bleeding. And in both groups, you treat them with intravenous fluids. Okay, and then, of course, when you look at high-risk patients, we talked about the incidence of upper GI bleeding mimicking lower GI bleeds in some patients. Hemodynamically unstable and tolerant to colonoscopy prep patients that go directly to interventional radiology or surgery. And then we have hemodynamically stable patients with upper GI bleeding that in turn are able to be prepped and go for colonoscopy. And then that intersects here with those same patients that are stable going for colonoscopy and then remain hemodynamically stable. We do colonoscopy next available for with after GoLightly or polyethylene glucose solution until the stool is clear of blood and stool. One of the challenges we have is that what you see is what you get in endoscopy. If the bowel prep is poor, you don't see anything, and you'll never may miss entirely a lesion that's substantial in size or impact on the patient's vasculature. So what we like to do is get as good a prep as possible to make the bowel visually acceptable, so that we can do the best job we can for both the patient as well as to prevent re-prepping and resource wastage. You can see these are. It's important to know what patients fall into what categories. If a patient's unstable, cannot drink the prep, cannot be stabilized hemodynamically, our interventional radiology colleagues help us many times by taking that patient directly in, because they do not require that degree of colon prep in order to achieve the same objective that we would try through the colon lumen. So this slide, I know it's busy again, but really what I wanted to reinforce is the risk factors for poor outcomes and lower GI bleeding are really the same ones that we see for upper GI bleeding. And this was a paper published by Straight and Granick in the American Journal of Gastroenterology. This is part of the American College of Gastroenterology consensus guidelines for lower GI bleeding. And here you can see that patients with continuing hemorrhage and with coagulopathies, with age over 60 or 65 years are all impactful in terms of the risks for that patient presenting with lower GI bleeding. So what about the other diseases that cause GI bleeding? This sort of takes us into the area that we hope we've made some small impact. We have obscuring GI bleeding sources in or out of the range of the endoscope are hard to identify. And really what we're talking about is we can scope through the stomach and do proximal duodenum. We can do a colonoscopy through the colon and most of the time to the small bowel through the ileum. However, to do more extensive investigations require specialized time-consuming techniques such as the push enteroscope and pill cams, which are now available. The pill cam does not have the opportunity to do anything therapeutic. It is a visual tool, but the push enteroscope can be used occasionally to endoscopic ablation. New patients at risk include LVAD patients, and the cardiologists know well about these patients in Heide syndrome with aortic stenosis. Great exam question. I spent years telling people that Heide syndrome was subject to a statistical error and not a real condition. However, I'm now a convert, and Heide's does exist, associated with angioectasias as well, and should be remembered for the clinical observation that occurred in identifying that syndrome. Imbalance between proangiogenic and antiangiogenic factors, including VEGF, are very important in the cause of lower GI bleeding. Vascular endothelial growth factor is really an end effector substance that produces vasculature, that such as we saw with that angioectasia. There have been studies published recently about Avastin with the with chemotherapy agents used that are effective against VEGF. However, you have to realize that it is an end substance, and we're interested in things upstream of this that might be targetable as interventions before these lesions become problematic. So the VEGF will show how it's there, how we expected that, and how it has been used therapeutically. However, we believe that the identifying of the difference in the etiology occurred at a higher upstream point. Angiogenesis inhibitors such as thalidomide, lenalidomide, and octreotide are pharmacologic agents used in the treatment of angioectasias. However, these don't work that well. Many of them target tumor necrosis factor, or TNF, and in particular, octreotide does not have the clinical benefit that a good drug therapy would have for a condition such as this. So don't look at this slide except for the fact that it's Trinetics. This is a program that's used to mine EPIC medical record thing, and I'm excited it's coming because Trinetics allowed us to look at my team to look at over 1 million patient records and to identify which patients had bleeding likely due to angioectasia, and to start to look for factors that were either impactful in terms of triggering or controlling angioectasia, which gave us clues towards the pathophysiology of these lesions. And that next slide will show you what we came up with. If you look at this, this is looking at a heat map of murine knockout models using angioectasia that were used to construct a gene regulatory network of pathways. So we looked at patients and they said, okay, what pathways will be impactful in terms of producing angioectasia? And if you can see here across the center, there's PPAR gamma, there's HIF1, hypoxia-inducing factor 1A, and there's VEGF. We thought, okay, so these are all the expected pathways, and since these are lesions that should be associated with VEGF, let's see what if we can confirm these findings with biopsies of human tissue with patients affected and control patients that give informed consent in an IRB approved study. And what we did that. Biopsy tissue, and we looked for HIF, the hypoxia-inducing factor, an inflammatory molecule called PPAR, vascular endothelial growth factor, if you look here down at this white box at the bottom right, F-beta, which is an inflammatory molecule. Now, of all those, the surprising ones, the others were expected. They were higher in the angioectasia patients, but the one that was surprising was TGF-beta. And you can see here on the top line, TGF-beta was increased in inflammation. It's also increased in inflammatory bowel disease of some forms, but it is an important finding because it tells us that angioectasias are associated with in a form of intestinal inflammation that has hitherto not been identified in humans. So what we've come up with, and hopefully come up with, is that we know that there's an effect on bleeding, of production of certain bleeding lesions such as angioectasia by a number of factors which are known to be associated with this, would include age, types of medications, blood flow and shear rates, which the cardiologists tell us are important and found to be important with Heidi's syndrome, kidney function, genetics, and the metabolic status of the host. We also know from some biopsies that I didn't show you is that TGF-beta seems to be associated with changes in epithelial glycosylation. Glycosylation are types of receptors in the epithelium that are essentially associated with good bacterial colonization of the intestinal lumen. This has become a very hot topic in medicine. I know that many diseases have been associated with changes in gut flora. However, this is certainly the case with angioectasia. Diet, medications such as antibiotics, and environmental factors associated, as well as host age, microbiome, and metabolic state of the host and microbiome are all important for these types of conditions. So take away home points, resuscitate your patients adequately and risk stratify patients. Perform endoscopy hopefully within 24 hours after they're medically stable. IV PPI drip for 72 hours or bolus if endoscopic therapy is done. I always put patients on BID PPIs for at least 2 weeks after and drop it down to once a day after that. Lower GI bleeding management is based on risk levels and colon prep status. New understanding of the role of inflammation and hypoxia will guide our management of angioectasia and potentially diverticular bleeds. Something else I didn't say is that there is a commonality between angioectasia and diverticular bleeding. Before we go into detail about the role of fiber and other things in diverticuli, there is a big role to be played by managing the gut colony and the gut flora in patients at risk for these conditions. Those need to be considered as well. The team approach, including interventional radiology, surgeons, and the ICU, are all key to good outcomes in our patients. Be aware of changes in the management and new upper GI bleeding guidelines. I think with that, I will pause for questions. I appreciate any feedback you might have.
All right.
That was a fantastic rounds. Too many microphones going. And are there any questions?
Bruce, hopefully I'll be able to talk without the reverb here. Somebody's got an open mic.
I think what could be the best bet, if you want to type a question in the chat feature, that might be a little easier than to save everybody's eardrums.
Jason, for whatever reason, I'm not pulling up the chat side. So is there any way for you to share that with me, or?
Yeah, if something comes up, I'll let you know if you want to give it a minute here. But everyone, if anyone, as I mentioned, it might be easier with the audio issues. If you have a question for Dr. Yacyshyn, to post it on the chat feature on the right side of the screen there.
And Dr. Yacyshyn, if you would stop sharing your screen, you'll be able to bring up your chat.
Yeah, I've got it there. Thank you.
Okay, Dr. Yacyshyn, there's a question, I believe it's from Dr. Dryden, and he is asking if TGF-B has a role in restitution as well as inflammation, but often in settings of fibrosis. SMAD7 inhibitor showed benefit in IBD early in course of development, but not in phase 3. Could this therapy have a role in AEC?
Yeah, that's a good question, or one that I would expect from Dr. Dryden. Thank you for that. I would say that those are good points. Yes, I agree. I think I think obviously risk benefit of any therapy depends on what stage of the condition you have. I find that it would be difficult to treat someone with that early on in the inflammatory pathway, early on in inflammatory lesion development or diverticular development because of the potential risks of those types of drugs. But what we're looking for is relatively safe compounds that could be given early on to expand flora, decrease inflammation. One of the groups of molecules that are very interesting are the oral hypoglycemics. So far, those would be an off-label indication for gut inflammation or for vascular ectasias. But given the right clinical context in a patient with diabetes, those might be an appropriate option for therapy even now.
Echoes. Great. Problems.
Yeah, I'm not sure what's causing that, but we'll definitely look into it. But I guess if you guys figure this is a wrap, then we had a lot of fun this morning.
Thank you, Jason.
Thank you.
Thank you guys. All right, thank you everybody, and we'll see you next week.